A warm welcome to everybody. And today's session is regarding the temporomandibular dysfunctions. And getting into this chapter, first of all, I like to enlighten you the basic principles regarding the anatomical structures of TMJ. And before going into this TMJ, when you look at this, the principle behind this joint is, it is the joint that is attached to the only joint that is attached to the skull. The lower joint is purely a hinge joint. The upper one is freely movable. That is the sliding joint. When you see the bony compartments of this temporomandibular joint, it involves three bones: the articular eminence, the condyle of the mandible, and the ethmoid fossa. These are the three joints that principally forms the temporomandibular joint. And pertaining to this topic of discussion today, this temporomandibular disorders, it is clinically, it comprises of 30 conditions. Okay, it starts with a simple joint pain, end up with crepitus or clicking. Usually, this temporomandibular joint disorders are referred to as TMD. One is the disorders of the joint, including the disc and the muscles of mastication, the disorders of the muscles that is for chewing. And the third is the headache that is concerned with this TMD. Now, the compound notes, when you classify the temporomandibular disorders, okay, now look at this structure of temporomandibular joint. As I told you, the main cause for TMD either can be in the joint, or it can involve the disc, or it can be a headache that is associated with this temporomandibular disorders. The three bones, mostly the condyle, the glenoid fossa, and the articular eminence. This forms the skeletal components of this joint. And intervening with this is the articular disc, that is the meniscus. Okay, it is attached to the head of the condyle. Okay, anteriorly it has, see, this is the head of the condyle, and this is the neck of the condyle. And the mandible is suspended by these two joints. And this, when you see the structure in individual, the articular eminence, that is, this is the articulating surface of the TMJ. Primarily, there's something called as lockjaw, or where you will have the attrition of this articular eminence. And the glenoid fossa, it forms the roof of the glenoid fossa. any injury to the joint, it start with a pain. Any injury to the disc will start with the pain in the chewing muscles, or it can spread to the face or neck. And in some cases, you can see stiffness of the jaw. These things are mainly associated with injury to the disc. If suppose there is attrition of the articular eminence, that will have a varied range of jaw movements. The lateral movements, patient will exhibit painful clicking when he is opening or closing his mouth. Or it can extend to the ears also, ringing in the ears, hearing loss or dizziness. And it will end up with a deranged occlusion. And when you see the TMJ as a structure, it has two compartments. One is the temporodiscal. You can divide the entire structure into two. One is the temporodiscal and the other one is the condylodiscal. These are the two. This is how the articular eminence divides the joint space into two compartments. And when you see the picture, you can see the upper joint compartment and the lower joint compartment. The significance of this we'll discuss later. This is the condylar process, fibrocartilage, and this is the cartilage that is associated with the joint. We saw about the skeletal parts involving the condyle, articular eminence, and the glenoid fossa. Those things are the skeletal parts. Now, when you compare, when you go to the next structure, that is the soft tissue structure of the TMJ, comes your fibrous capsule. Fibrous capsule, the dense collagenous membrane that divides the into upper and the lower compartment. And when you see in the lateral view, you can examine how it is attached to the bone, the lateral ligament and the articular capsule, how it is attached to the zygomatic process of the temporal bone. Now the ligaments. One is the collateral ligament, then the capsular ligament, temporomandibular ligament, stylomandibular ligament, and the spinomandibular ligaments. First, we saw about the capsule part. Next is the ligaments. And before going into the structure when you see the sagittal section of the temporomandibular joint, the mandibular fossa is visible. The superior compartment as the upper and the lower, superior compartment and the inferior compartment in between with the articular disc. This is the sagittal section of your temporomandibular joint. This is the ligaments we discussed. The medial collateral ligament and the lateral collateral ligament. And coming to the temporomandibular disorders, it is termed as TMDs. It is the disruption or the defect in the internal aspects of the TMJ, in which there will be an abnormal relationship between the disc and the condyle, fossa and the articular evidence. This is termed as the temporomandibular disorders. It is a collective term with it is a group of 30 conditions, okay, that cause pain, dysfunction in the jaw and muscles that controls the jaw movements. And the three main classes of TMD is can be with the disorders of the joint, disorders of the muscle, and the headache. And it can be broadly classified into two, involving the either it can be articular or non-articular. Can be a inflammatory condition of the articular disc. It can vary with synovitis or capsulitis or arthritis, osteoarthritis or polyarthritis. That is the inflammatory condition of the temporomandibular joint pertaining to the articular disc. And the non-inflammatory condition, the articular disc reduction, deviation will be there. Non-inflammatory, it can be that is more with can be ankylosed joint. This is regarding the articular surface, articular disc. Then the next one is non-articular. Non-articular, mostly with the problem with the muscles of mastication, the attachment of lateral pterygoids. Pain in the chewing gums or jaw stiffness, myositis, MPTS, spasm or contraction of the muscle. Now you should be very clear when you differentiate the temporomandibular disorders. Either it can be associated with articular or muscular. Broadly, it can be either in the disc or in the muscle. Most of the defect that is associated with muscle is restricted jaw movements. Patient can't open his mouth, or can be muscular spasm or muscle contracture. That is with the non-articular type of TMD. The articular type of TMD is with the problem that is arising in the capsule or the articular disc. And the disorders, that is the dearrangements of the condyle or the disc complex. That is one. That is the most commonest. That is the primary TMJ disorder. Next is the structural incompatibility of the articular surface. The third one is the inflammatory disorders. Injury to the jaw or the temporomandibular disc will lead to this temporomandibular disorders, most of the cases. But clinically, for many people, the symptoms starts with any obvious reason. Recent research suggests a combination of genetic factor or psychological factor, and more commonly it is associated with stress and how someone perceives the pain. It is more commonly seen in females. And now the recent research is whether it is associated with any difference that is seen in the TMJ structure and the mechanics of these jaw movements. And when you want to really diagnose these disorders, there is no widely accepted a standard test to exactly diagnose these TMDs, because the exact causes and the symptoms are not clear, and identifying these disorders is not that easy. Your doctor or dentist will note your symptoms and take a detailed medical history. Ask question about your pain, including its location. Also, other pain such as whether it is associated with any back pain, shoulder pain, or headache. And when you examine this TMJ, you have to examine the associated structures also, your shoulder, neck, ear, and confirmation can be done only with an X-ray or an MRI or CT. Pain in the mouth, jaw may not be related to temporomandibular disorders. You have to individually check the intraorally. You have to check whether any pathology is there in the mouth. It can be unerupted tooth, mostly the third molars, and the lower third molars. Most commonly, that is the one that is mostly impacted. You have to individually assess the oral cavity and associated structures. Even a shoulder pain will mimic a temporomandibular disorder or pain. And as we previously discussed, it is not a single problem. It is collection of 30 conditions. And before going into this temporomandibular disorders, just a quick review of this sagittal section of this temporomandibular joint. Okay. The articular disc that divides the joint space into upper and the lower compartment. Now we have to bother about this muscular attachments also. Muscular attachment is the lateral pterygoid muscle. Okay, that is attached to the head of the condyle, and the ligaments. The capsular ligament, the temporomandibular ligament, the stylomandibular ligament, and the spinomandibular ligament. The first basic symptom that is noticed is there will be pain and the joint movement will be compromised. Since the temporomandibular joint acts as the sliding hinge, mostly it is self-diagnosable. That might be difficulty in chewing also, or pain can worsen when there is chewing, when there is clenching or any hard diet. That time also the pain will be aggravated. Mostly the collateral ligament, the capsular ligament, and the temporomandibular ligament, most of these ligamental pain will be in with, will have severe pain. The myofascial pain disorder, the other terminology that is most commonly used to denote the temporomandibular disorders. And this is regarding the how it is diagnosed. is regarding the now this articular disc arises from the elongation of this discal ligament and the inferior rectal lamina. As I said earlier, the lateral pterygoid muscle, it's more attached anteriorly to this. When this pull is constant, and when you see this picture of this disc, see, when this pull is constant, there will be thinning of the posterior border of the disc, displacement in the anterior push. And this represents the early stage of disc rearrangement. And the elongation of the capsular disc, capsular ligament and the discal ligaments with the thinning of the disc, that causes the internal dearrangement of the temporomandibular joint, mostly associated with a trauma. This disc dislocation with reduction. See, prior to this, when you look at this disc, arises from the elongation of the discal ligament and the inferior retrodiscal lamina. Now, when you see this, we'll have a elongation of the capsular and the discal ligament coupled with the thinning of the articular disc. Commonly, it is due to the trauma. This is the first condition. This is with reduction. The second is without reduction. That is the disc dislocation without reduction. This clinical condition is most frequently seen anteromedially from the condyle and doesn't return to normal position with the condylar movements. The clinical condition, that is, now when you see the picture, you can very well notice where the disc is dislocated and most frequently anteromedially it is dislocated from the condyle and doesn't return to the normal position. This is with any major trauma. Main reason is any major trauma to the temporomandibular disc. See, this is the condition with disc dislocation with reduction. This is without reduction. You should be in a position to differentiate this two. Wherein the first condition will have the elongation of the capsular and discal ligaments. The second condition will have, see, this is without reduction. When the head doesn't return to the normal position. And when you see this, we'll have to, that is with regarding to opening and closing of the mouth. The first one is the closed position. When the mouth is closed, this is the position of the temporomandibular joint. The other one is the associated with the, that is open condition. Unable to return to the dislocated disc due to the, disorder called as lockjaw. Non-reducing disc displacement can be again can be either acute or chronic. And regarding the signs and symptoms, it can vary from pain or abnormal joint sounds. And these things can be crepitus or clicking. That is very well auscultated with your steth also. Abnormal joint sounds. Restricted mouth opening, that is the limitation of mandibular movements. The lower jaw will be restricted. The lateral movements will be restricted, and opening also will be restricted. There is the other way, a trismus. And if it is so severe, can end up with pain in the ear also, ear symptoms. And basically, it can be associated with recurrent headaches also. See, typically, the signs and symptoms of this TMD, it can be associated with simple disc, articular disc problem, or the pain associated with the muscles of mastication, or it can be associated with the headache. Now, when you see the prior before this, see, when you see this, either it can be associated with the disc or non-articular, that is with associated with the muscles, a muscle spasm, or myositis, or contraction of the muscle, or it can be associated with headache, that is recurrent headache. This is the signs and symptoms of the TMJ. And the muscles of mastication, mechanical trauma, or muscle fatigue, or can be a inflammatory condition, as discussed earlier. Inflammatory condition of the articular disc. See, this is the inflammatory. It can be or synovitis or capsulitis, or it can be associated with osteoarthritis. It can affect the, as all other joints in the human body, it can also similarly affect the temporomandibular joint. This is the inflammatory condition. And now the muscle fatigue, the muscular pattern. It can be in the problem with the muscles. It's got sustained static muscle contraction. Patient will have myofascial pain, or myogenic pain, or a foot pain. And this the sounds, the joint sounds, grating or scraping noise can be roughened or irregular articular surface of the osteoarthritic joint. This arises only when there is uncoordinated movement of the condylar head and TMJ disc. Now, when you assess the causes of the TMJ clicking, deviation, first is the dysfunction. That is deviation in the form of condyle, disc, and the temporal fossa. The next is the neuromuscular dysfunction, or eminent clicking will be seen when there is post joint opening. And if it is any anterior disc displacement, we'll have clicking, or if there is any hypermobility. The next is the third disc click, mostly associated with trauma. The other associated symptom is tenderness in the joint, can be a facial pain or difficulty in moving the joint. The inflammatory disorders of the articular disc, the synovitis, capsulitis, retrodiscitis, or temporal tendonitis. The ligament, as we seen earlier, I'll brush up the ligaments. The capsular ligament, the temporomandibular ligament, the stylomandibular ligament, and the sphenomandibular ligament. Just see the ligaments. If any inflammatory condition associated with this ligament, patient will have. And a quick review of this topic: pain that is felt in the face, a stiffness of the muscles of the jaw, and when you see any limited movement of the jaw, or if there is any locking of the jaw, or clicking, propping of the clicking or crepitus, any headaches, you should ascertain the temporomandibular joint before arriving to any conclusion. And before winding up this section, I thank you one and all for your patient listening.